Brilliant. So I might start. Just firstly, let me welcome you all to this month's Monash Addiction Research Centre interdisciplinary webinar series. We've got an exciting program for you today on the socioeconomic lens on addiction. Some of the key experts, at Monash who work in this space, who'll be talking about both the economic factors that sort of influence alcohol and drug use and whether those policies around those are working, and also the social determinants and social factors that underpin pathways and engagement in problematic drug use. So really exciting speakers for you today. Just before I introduce them, I'd just like to acknowledge the traditional custodians on the lands on which we work today and pay my respects to elders both past, present and emerging. Just before we introduce our speakers, I just want to give a plug to next month's webinar series. Kelly, I don't know if we have a slide on that. If not, brilliant. So we're delighted to welcome our first international speaker, so Associate Professor Kelly Dunn from Johns Hopkins University School of Medicine in the US. Who's going to be talking on a really exciting topic: can cannabinoids help us address the opioid crisis? And she'll be supported by Stella Liner, Rochelle Bookbinder, and Susie Nielsen from here at Monash, who'll be complementing her talk. So a really exciting talk about the role of cannabinoids in pain management and managing issues to do with opioids and the opioid crisis we see in the US. So please put that date in your diary, and I'm sure you'll be delighted with a really engaging speaker. So let's move on today to this webinar, and let me introduce the three great speakers that we have today. So I'm going to introduce the three speakers now, and then I'm going to hand over to each of them to give their respective talks. And so our first speaker today is Associate Professor Sonja Deneu, who's Senior Research Fellow at the Centre for Health Economics at Monash Business School. Sonja focuses her research on mental health economics and policy evaluation, with a particular focus on the mental health of disadvantaged populations. Her research projects investigate the impact of insecure work and financial stress on decision-making, skills, productivity, and life outcomes. She's also working on several projects related to risky behaviours, in particular the role of economic disadvantage and the evaluation of various policy changes to reduce risky behaviours. Sonja currently ranks in the top 10% of all economists and the top 6% of female economists worldwide. So it's a real delight to have her today. Our next speaker is Professor Philip Mendes, who's Director of the Social Inclusion and Social Policy Research Unit at the Department of Social Work here at Monash University. Philip research areas include young people transitioning from out-of-home care, income support, including compulsory income management, social workers and policy and practice, illicit drug policy, indigenous social policy, and Jewish community responses to institutional child sexual abuse. Philip has authored, edited 12 books, including the popular textbook, Australia's Welfare Wars, and is the author of more than 100 peer-reviewed academic journal articles and book chapters. And complementing this stellar lineup of speakers, we have Professor Aron Shlonsky, who's Head of Department of Social Work at Monash University. Aron's our discussant for today, and he's internationally known for his work in child and youth services, particularly in the generation, synthesis and implementation of evidence to inform practice and policy, as well as longitudinal data analysis in the child and family services field. He's been the primary chief investigator or co-investigator on over 70 contracts and grants in Australia internationally, and has authored and co-authored numerous other books, peer-reviewed articles, and government reports in the child protection and family services area. I'm sure you're in for a treat today with both Sonja, Philip and Aron really focusing on this really important issue of a socio-economic perspective as we think about addiction. So on that, just before I hand over to Sonja, I'd just like to direct people to the question and answer feature on Zoom. So if you have any questions, please do not put them in the chat section. but please put them in the Q&A section, and Aron will be reading those throughout the presentations, and we'll be presenting those questions to our two presenters. So thanks again. I'm delighted to welcome Sonja. So please put your hands together and welcome Sonja.
Thank you very much, Dan, and everyone. Thanks for the nice introduction. Let me just bring up my presentation. There we go. Yes, so today in this webinar, we look at addiction through a socioeconomic lens. And I would like, therefore, in my presentation, to take the opportunity to talk about the opportunity that we target addiction through social policy rather than healthcare policy. And I think often we really focus on how can we treat addiction medically, and we don't really think about how we can maybe potentially even prevent addiction through social policy. Now, for this to happen, for social policy to be able to prevent or influence addiction, of course, we have to make the case that social policy can influence certain factors like income, poverty, level of education, and neighborhood deprivation, and that these factors causally influence addiction. Only then, of course, social policy make a difference. So we know there is an interrelationship between mental illness and addiction and low socioeconomic status, low SES. Previous studies have shown that low income, low levels of education, and neighborhood deprivation are associated with a 1.5 to 3 times increased risk of mental illness, and also more generally with lower levels of well-being. Now, of course, because addictive behaviors are often used as coping mechanisms for mental illness, and addictive behaviors and mental illness often occur at the same time, it is not surprising that previous research has also shown that low socioeconomic status is associated with increased risk of substance use disorders, in particular alcohol use, opioid use, and tobacco use. But of course, what is a little bit less known is, what is the direction of this relationship here? Because there is this bidirectional relationship that we have between addiction and poverty or low SES. And we also don't know that much about the pathways through which poverty can influence addiction. And therefore, I've put here this little picture where you see about the circular relationship that I'm talking about. So poverty can influence, for example, worries about economic situation due to the increased uncertainty about individuals' financial situation, and that may impact on mood and anxiety disorders and consequently also on addiction. It's also possible that poverty impacts on physical health, and physical health could directly impact on mental illness or indirectly through the increased pressures through having, certain monetary constraints that come with the physical illness. Poverty could also influence early life conditions. For example, we know that it may impact on individuals' educations and may impact on parenting, on supervision that parents can provide for their children because they are also under stress because of poverty. And again, this could impact on addiction. Poverty could influence violence and crime. So individuals who live in poverty are at increased risk of experiencing violence and crime. They may be at increased risk of losing a family member, losing a friend. And again, this puts a lot of pressure on individuals, which could reduce mental health. And then, of course, also social status due to poverty, due to the increased pressures that everyone faces if one has a low social status, could also lead to mood and anxiety disorders and consequently addiction. And then at the same time, it's also possible that addiction and mental health issues influence productivity and labor supply. It may also influence preferences and beliefs. So individuals who cope with addiction or with mental illness more generally may be more risk averse. They may have more pessimistic beliefs about their future, and then consequently that may impact on their economic decision making, and they may maybe make suboptimal decisions. May also influence women's empowerment and also childhood development, their education, etc. And all of this could then influence poverty, and then we've got this circular relationship. And so while I think we do have that circular relationship, but if we want to make this case that social policy can help, we really have to think about, okay, can we make the case that social policy can influence poverty, and poverty can really impact here on addiction. So is there a causal relationship? And I would like to make the case in my presentation that I think there is definitely a causal relationship. So my own research, for example, has looked at this. Here we looked at mental health outcomes of around 10,000 individuals in the US with the Health and Retirement Survey. Individuals are aged 51 and over, and we know whether they have depressive symptoms, whether they have anxiety. We also know their level of life satisfaction. And we also know whether they've grown up during childhood in a family that was financially well off, or a family that wasn't financially well off. And so what we show here is that if individuals grew up in a family that was financially well off, this reduced their probability to have depressive symptoms later in adulthood. They have a reduced probability of having anxiety, and they have higher levels of life satisfaction. What we also could look at is the polygenic risk score. So if individuals have the genetic risk for depression, anxiety, or mental illness, they are, of course, also at increased risk later in life to experience these illnesses. But what was really interesting is that for those individuals with the same level of genetic risk, if they came from a family that was financially well off, that was a protective factor. So that could reduce their probability of experiencing the mental illness later in life, even though they have the genetic risk for depression or for anxiety. So that was quite an interesting finding. And then we wanted to know more about, okay, can this be explained by different parenting styles, child abuse, parental drug use? So other factors, what are the pathways? What factors are related here with family socioeconomic status? And we didn't find that actually any of these factors could explain this protective effect of socioeconomic status during childhood. But we did find, or we conclude basically from this, that likely it is financial resources that, for example, give individuals better healthcare access, better schooling, more supervision. Parents are less worried, can focus more on the children, and that may have this protective factor for people with a genetic risk factor for depression or anxiety to develop these issues. So of course, and again, I think then it is very, very likely that this kind of addiction follows from that as well. But in this data, we couldn't look at addiction, unfortunately, because we didn't have this in the data. But the case that I think I want to make here is that, there seems to be something going on with socioeconomic status, and it can be a protective factor. Now, I wanted to show you a little bit how big the problem of addiction actually is. So these graphs show you the prevalence of addiction at the macroeconomic level for the United States. But here I look at, obviously, just the very extreme outcome of mortality, so deaths. So to the left, you see all-cause mortality for ages 45 to 55. And on the right, you see mortality by specific cause. And so the bold red line is for the United States whites, and the bold blue line is for Hispanics in the United States. And then you've got some other countries as well, including Australia, which is the dark red line. And so what is interesting is that you see until around 2000, mortality dropped, and then suddenly we have a reversal of this trend, and mortality starts to increase for whites in the US. We don't see this in any of the other countries, but if you do look at Australia, you do see that mortality is just, it's kind of leveling. The downward trend here is kind of leveling off, so a little bit mirroring the US. And then if we look at, okay, where is this coming from? If we look at the graph to the right, we really see a really strong increase in poisoning deaths. We also see an increase in suicide over the same time period. Interestingly, we also see an increase in chronic liver diseases. So essentially deaths associated with very heavy drinking, alcohol misuse. We don't see much going on here for diabetes. It's pretty much stable, death to diabetes, and lung cancer going down, which is also like a common finding that, we know a lot more about how harmful tobacco use is, and there has been a lot of work in that area. But yeah, you see that addiction plays a role even in reversing the downward trend of mortality in the US. And while we observe these graphs or these trends, at the same time, what's been happening in the US is that we've had widening widening income inequality. We've had very slow wage growth in real median earnings, especially those with low education. And at the same time, we have had increasing reports of pain. In fact, there is a paper that showed that 50% of prime-aged men who are not in the labor force take pain medication daily, and 2/3 of which take prescription pain medication. So yeah, it definitely does seem to be the case that there is a kind of socioeconomic component to addiction and to these increases in deaths, in particular due to poisoning. We can then look at similar graphs for Australia. So here you see the development of all poisoning deaths to the left and opioid deaths in the right graph. And we see similar steep increases over the same time period in Australia. In particular, we see like around the global financial crisis in 2009, we see a spike there where poisoning deaths increased. And we see really that these increases are driven by opioid deaths. And again, we see for opioid deaths here a spike around 2009. And yeah, since 2006, these were mainly driven by natural and semi-synthetic opioids. And then since 2012, more like the synthetic opioids coming in, and also increases in heroin more recently. So we can also split opioid or the regions in those regions that are in the kind of top quartile with respect to the unemployment rates in Australia, those regions that are in the bottom quartile with the unemployment rate, and then those in the middle, to look at how do opioid deaths develop in these different regions. Again, we see the spike around the GFC in 2009. But what is really interesting is that those areas here, the kind of the black line and the dark blue line that have very high rates of unemployment, they continue to increase with respect to the opioid deaths. But we do see a leveling off here for the region, for the low unemployment regions. So again, making the case that something is going on with economic conditions and opioid use. We investigated this a little bit more formally as well by, we used the National Coronial Information System, the NCIS, where we looked at opioid deaths at the regional level, the SF4 level, and we looked at how do economic conditions as measured by the regional unemployment rate, how do they impact on opioid deaths of the regions. And we controlled in these estimations for area fixed effects. So anything that is unobserved but specific to the area and doesn't change over time, and time fixed effects. So anything that is unobserved but happens at the same time and affects all regions. For example, macroeconomic shocks at the kind of macro or national level. And we also control for area specific linear time trends. And so what this analysis showed us that here the first number, we see that as unemployment increases by 1 percentage point, this increases opioid deaths by 0.138 deaths, or if we, per 100,000 individuals, or if we put this in relation to the mean to give a better understanding, what does it actually mean? It's an increase of 4%. We see that unemployment increases both intentional and accidental death. And interestingly, and this is also consistent with evidence from the US, we see an increase mainly for males, not for females, and again, this prime working age group. So men in the prime working age group were affected. And also we found the effects was concentrated among those individuals who were previously employed. So again, there seems to be something going on with socioeconomic conditions. We can then split up the effect by looking at different occupations. So opioid death rates for certain occupations and opioid death rates by the different skill levels. And we see everything, the whole effect is concentrated. So it's among those who previously worked as machine operators, drivers, laborers. And if you look at the skill level, among those with low levels of, low skill levels. So working in occupations with low levels, skill levels. Yeah, so to summarize these points, a 1 percentage point increase in the unemployment rate increased opioid deaths by 4%. That's what this paper showed. We identified the vulnerable groups, male, so men in the prime working age groups, those who worked as laborers previously, low skilled, the employed were affected, and we found that both accidental and intentional deaths were affected by an increase in the unemployment rate. We also looked at, and I didn't show you that, but we did also look at a more longer term. So how does the change in the unemployment rate between 2006 and 2016 was associated with changes in opioid deaths over the same time period? And we found that it explained around 15% of the increase in male prime working age opioid death rates. So, which I think is quite a sizable proportion. We were then, like once we had this information, we were also really interested to kind of understand a little bit more on the pathways. And we couldn't do this in Australia, but we looked at this in Germany. And here we didn't, unfortunately, have information on addiction in this data set. So we focused here on mental health. But we were really interested to see, is it really do individuals have to experience unemployment or income losses to have their mental health and consequently addiction affected? Or do the effects operate through just these worries, the subjective experience of this economic uncertainty? And so at the top, we kind of, first of all, just looked at, okay, is mental health affected by economic conditions? Here we looked at, we measured changes in economic conditions by changes in regional level GDP. And we saw, yeah, as economic conditions improve, mental health summary score based from the SF-36 improves, and the subcomponents, all of the subcomponents pretty much improved as well. We saw that as economic conditions improved, it reduced hospitalizations due to depressive disorders, single episodes, recurring episodes, and also due to toxic effects due to non-medical substances. We find actually a positive effect here on alcohol use, which has also been found in the literature before in other countries, in the US, where this is likely due to the income effect. So as economic conditions improve, worries are less. So maybe you would expect people to need alcohol much less, but because they have more income, they can also drink more. So that's why you see this positive effect for alcohol here. And then what we were really mostly interested in were these objective versus these subjective measures to really see, okay, do individuals have to become unemployed? Do they have to have this loss in income to experience these mental health decreases? And what we found really everything that it operates through these worries. So yeah, if the unemployment rate, or in this case, if economic conditions improve, it really, really improves also the worries that individuals have about their own, about their job loss, and also about their own economic situation. And again, we would think that these would flow on to addiction as well. We then, with this German data, we also looked more generally at the impact of the Great Recession on mental health and on well-being, like a measure of well-being more generally. And we found that mental health was really actually quite persistently affected and long-term affected by the Great Depression here in 2009. As you see, mental health drops off and it didn't recover since then. That's where our data ended. And similarly for life satisfaction, and you even see that life satisfaction was affected already before. Actually, there was the realized impacts of the recession, and that was because people were already talking about it. So there was already an anticipatory effect in well-being, which is arguably more sensitive to these changes. But I think the important point here to make is that, yeah, so it is possible that if individuals kind of, confidence in the labor market, confidence in the economic situation is impacted, that could actually flow on long-term onto people's mental health, life satisfaction, and consequently also likely addiction as a coping mechanism with these issues. With respect to policy implications, yeah, so I think it is important that we do reduce economic insecurity for individuals. Employment protection, of course, is really, really important. It's great that we had JobKeeper and JobSeeker. I think we can also think about moving to more like an unemployment insurance system, where individuals, like in other countries, they know that if they become unemployed, they will have, for example, 60% of their previous wage for a year guaranteed. So they know they have this buffer, and that may help with these feelings of insecurity that could spill over on mental health and addiction. Generally, it also means we should probably allocate more resources to treating substance use disorders and mental illness when economic insecurity is high. And the fact that we found these strong reactions to individuals' perceived rather than realized economic situations, I think mean that really we have to have really good communication of the existing economic and social safety net, so that people don't have this, get into this stress and these worries about what could potentially happen to their economic situation, to their job, to their income, when they don't even necessarily experience a drop in income or a job loss. So I think just having a really good safety net would really, really help, and communicating how good that safety net is. Of course, implications for the pandemic are there too. We know that those who lost their job due to the pandemic already had quite low levels of financial well-being. So again, it's the really disadvantaged that are hit again. And we know that while we didn't see much happening in terms of increased suicides thus far, we do see already indicators of lower levels of mental well-being. And I think once, you know, the support is more phased off, there is a possibility that we may see mental illness, or it may have to wait a little bit until we see mental health to improve again. I think also it's important to note that economic shocks can only partly explain rising opioids harm, and it's likely that there are a number of other root causes. So specifically for opioids, of course, this depends on what addiction we are looking at, but specifically for opioids, and I've talked about them here, is that economic conditions are likely to interact with supply side factors as well, such as drug availability. We know there was the opioid epidemic. Suddenly, you know, there were a lot of prescriptions for opioids, and so of course that interacts as well with the economic conditions and whether people use opioids. And with respect to future research, I really would like to think about and have everyone think about, do we maybe need to combine economic and mental health and addiction interventions rather than just focusing on addiction interventions or just focusing on economic intervention? Maybe the best intervention is that combines economic and mental health and addiction interventions. Yeah, thank you very much. That is it for me. And I think I will then hand over to Philip. Thank you very much.
Thank you, Sonja. Hello, everybody. As a researcher, I've long had a particular interest in the social context of illicit drug use, including the complex relationships between substance use and a range of broader issues and factors such as housing and homelessness, the long-term impact of child abuse and neglect, involvement with the criminal justice system, and financial poverty. So today I'm going to address three main objectives, one being identifying why, in my opinion, addiction and particularly problematic drug use is mostly a result of both social deprivation and personal trauma. Two, I'm going to look at two examples of that link between addiction and social deprivation, one being young people transitioning from out-of-home care, such as foster care or kinship care or residential care, and also participants in current conditional welfare programs, such as the Basics card and the cashless debit card. And three, present a potential structural solution to this social problem. Slide 3, thank you. So part 1, the social context of problematic drug use. Popular depictions of the drugs problem often suggest that injecting drug use has come from all walks of life. In the 1980s, former Young Talent Time entertainer Debbie Byrne was often presented as the stereotypical middle-class user. The tabloid media still tend to highlight stories of drug use and abuse at privileged private schools. Yet the reality is rather different. There is a lot of evidence to suggest that most addicts come from poor or socially disadvantaged backgrounds. There is also evidence to suggest that many of the users who come from middle class or affluent backgrounds have experienced significant personal trauma involving violence, abuse, and/or grief. The Swedish social work academic Ted Goldberg, in his 1999 seminal work, Demystifying Drugs, identified that persons from what he called the lowest social stratum were markedly overrepresented among problematic consumers. He identified a number of factors that were likely to contribute to increased heroin use, including high unemployment, limited access to education, segregated housing, racism towards immigrants, and traumatic refugee experiences. Other important psychosocial factors included parents who were alcoholics, experiences of physical, sexual, or emotional abuse, and poor family relations. Australian research shares many similar assumptions. Going back to the 1996 Victorian Premier's Drug Advisory Council, when Jeff Kennett was still Premier, that report identified drug use with socioeconomic disadvantage and emotional disorder. Marginalised young people lacking education or family support were considered to be particularly vulnerable. Similarly, the recent survey of users frequenting the Richmond medically supervised injecting room in Melbourne shows that they are more likely to be unemployed, reside in unstable accommodation or be homeless, identify as Aboriginal, or have been in prison in the last 12 months. And a surveyed group of the regular users of the King's Cross New South Wales injecting facility reported 96% had a history of trauma, 82% had a mental health diagnosis, and 54% had attempted suicide, and 1/3 had a history of self-harm. So injecting drug use can potentially be seen by users as a solution to deep-seated social, economic, and emotional problems. Just as some of the mentally ill use heroin to self-medicate, so many drug users appear to use heroin or other injected drugs to relieve their emotional pain. The demonstrated relationship between problematic drug use and emotional pain suggests that any policy solution will need to involve positive social and emotional supports and opportunities that specifically address existing feelings of hopelessness and frustration. Next slide, thank you. So part 2, problematic substance use within specific disadvantaged populations. So one group that I've researched is young people transitioning from out-of-home care. And a number of studies have reported that that group, who we often call care leavers, are more likely to be involved in problematic substance use. Now, of course, that doesn't mean most are involved in substance abuse, but just as they form a disproportionate component of the homeless population, so they may form a large proportion of chronic AOD users. For example, our recent national study of Aboriginal care leavers found that some of that cohort struggle with alcohol and drug use. Care leavers are disproportionately exposed to key factors for AOD abuse, including experiences of abuse and neglect, both prior to and during state care, poor housing and homelessness, pre-existing mental health problems, and prenatal exposure to drugs. It appears that many care leavers use substances to self-medicate, i.e. as a coping mechanism for the internal emotional pain brought about as a consequence of traumatic experiences, which may include the suicide of family members and experiences of sexual assault, rape, physical assault, and bullying. Substance abuse also seems to correlate with the absence of consistent caring and supportive relationships whilst in care, and premature and unplanned departures from out-of-home care, which compound substance use problems by causing unstable and transient living situations. A second cohort at risk are those Australians of working age on unemployment payments, i.e. the job seeker allowance, particularly the long-term unemployed cohort, who are currently targeted by a number of forms of conditional welfare. They are often framed by policymakers as the undeserving poor, who are assumed to have made bad individual choices completely unrelated to any experiences of unfair social and economic structures to engage in problematic substance use. So one example of conditional welfare is the long-standing targeting of people allegedly involved in AOD abuse by the introduction of various compulsory income management measures, including most recently cashless debit cards, affecting in total over 40,000 people nationally to date. A key assumption behind the income management program overall is that it will reduce forms of individual and community harm associated with AOD addiction, such as child abuse, crime, family violence, unemployment, and homelessness. Yet our recent ARC-funded study of 4 income management sites revealed that in fact many income management participants don't have pre-existing AOD addictions, that income management seems to have had limited impact on AOD abuse in the targeted sites, and that where some positive change has occurred, it is actually difficult to segregate the impact of income management from other discrete support programs and policies. In particular, income management does not address the complex underlying social, psychological, and medical causes of AOD abuse, such as poverty, a history of childhood trauma, and poor medical health. Another example of conditional welfare is the introduction, although to date not as yet passed by the upper house of the Commonwealth Parliament, of the proposed drug testing trial aimed at new recipients of unemployment payments. That trial aims to address substance use issues that allegedly act as barriers to seeking employment, and includes the planned placement of those who test positive on income management for 24 months. It is, however, unlikely this proposed policy will effectively address the broader causes of AOD addiction, which again go well beyond individual choice. Next slide, thank you. So part 3, a structural solution to problematic drug use, to sum up. So many writers present what we may call a generic structural solution to illicit drug use based broadly on proposals for the redistribution of wealth and income. The respected British political science journal, New Statesman, once famously argued that, quote, inequality and poverty breed drug dependence, unquote, and urged, quote, a war on poverty, not on drugs, unquote. But such generic structural formulas arguably don't specifically address the personal needs of existing and former drug users. It is, of course, true that structural social reforms may help to prevent a new generation of young people being drawn into poverty, homelessness, social isolation, and potentially into drug dependence. But it is unlikely that structural measures alone will help to rehabilitate those whose personal traumas are driving their drug usage. The latter group require both specific structural and personal assistance. Structural assistance would involve improved access to holistic primary health care, housing and employment, education and training services. Personal support would involve extending support well beyond the rehabilitation or withdrawal phase to offer ongoing counselling that addresses underlying emotional or psychological affliction. So in summary, policy solutions need to address both the personal and social causes of drug use. And the next slide there is really just a summary of the reading and then a very short bio at the end. So thank you, and I think back to Aron from here.
Hello, everybody. Very interesting. I think Philip and Sonja, you can probably turn on your screens and etc. So this is more of a facilitated discussion, and it was really interesting. I think you two probably came to the same conclusion, just in wildly different ways. With Sonja taking an economist point of view, and Philip, well, social policy and history and what you know from social work, which I think is interesting that from these different disciplines came to the same general conclusions. I guess the takeaways, there were a lot, but the ones that I will focus on from Sonja is really, well, poverty sucks. And I recall actually in grad school walking by a colleague's computer, and that was her screensaver. And we were all working in a center to address some of these structural and personal issues. And in the stuff that's been presented, we haven't even talked about kind of a lifetime of disadvantage and its effect. Maybe Philip, I think, touched on some of that, but snapshots of how people are going at certain points in time, or hints at what's happening, but the overall picture is probably bigger. The other one that I think both of you guys touched on is that poverty, the effects of poverty are not solved solely by improving income. Now, there can be some, obviously, improvements, but the effects of economic disadvantage linger, as is seen in some of Sonja's data. And the other interesting part from Sonja, I thought, was that subjective experience matters. It's not just that you maybe have a decrease in income, but so the worry about that can have implications for mental health and functioning, etc. And from Philip, the takeaway was disadvantage isn't limited to income. There's a huge social disadvantage and traumatic experiences which can drive addiction. And focusing on those who don't meet the criteria of having suffered disadvantage in some way. I think mostly if you dig deeper, everybody's vulnerable in some ways. But focusing on those that haven't is sort of a red herring that speaks to what we'd call in social work as a blame the victim mentality, where we blame people for their problems. And sure, people have agency, but there are structures in place that appear to be related to how people end up functioning, and certainly to addiction, mental health, etc. You identified some distinct populations that are most disadvantaged, and I would say that that's probably the best way to put it. I've heard people say, here you're at risk because you are, let's say, a young person transitioning from care, or you're at risk because you are from an Aboriginal or Torres Strait Islander heritage. It's the disadvantage that is suffered in those communities tends to be larger, and all the statistical models I run tend to really flatten out the impact of, let's say, Aboriginal and Torres Strait Islander status. Once the disadvantage is kind of washed away a bit, then the differences in outcomes tend to decrease. And then the other thing that I thought, Philip, that you talked about that was interesting was some of our solutions, like moving to income management, can be ineffective at best and harmful at worst. That changing, when we make assumptions about what's driving the behavior, and that those assumptions are limited to the personal, then the reforms that we make, structural as they may be, might not actually be the right solution. So there you have it. That was my takeaway from your fine talks. And we're starting to get questions. And I just like to give each of you a chance to respond to these. So the first one we have, and I get to click the button. We're answering this live. Can you comment from your different perspectives about what we know about the economic impacts of COVID on substance use and what we might expect this will look like over the longer term?
Yeah, so I think from my perspective, it is a little bit hard because of data availability. Because data, when I look at the macro level, and if I look at poisoning deaths, for example, that only becomes available with a very long lag. So we don't have that information yet. But from all the evidence I've seen is that there hasn't been an increase in suicides, which is also often, has the same trend as, for example, opioid deaths. So, and we have seen that mental health has decreased significantly during COVID. So I think there are mental health impacts that we are already observing. But obviously everything was buffered by the job keeper and job seeker, and some people even having more income than they had prior to COVID-19 because of the safety net, which is good. But I do think once this is removed, and from my research, I think we would expect addiction to increase in the long run, even though I think maybe in the short run, we don't necessarily see increases just now. But for me, I have to wait for more data, to be honest.
Aron, my response would be a little bit indirect, and that is that we're seeing some really good reports on the impact of COVID-19 on young people transitioning from care, coming through from people like Emily Munro in England and Bernie Kelly and colleagues in Northern Ireland, showing that because that group are already a group that are very socially isolated, they're very reliant on professional support workers and the supportive relationships with those professional workers rather than broader community support that most people have, that those professional supports have been eroded during COVID-19, often gravitating from in-person live meetings to Zoom or phone. And that has impacted adversely on their mental health. So we could perhaps surmise that for those who are already vulnerable to substance use, that probably could have accentuated that direction, unfortunately.
Interesting. Okay. And a bit of move to something else. Sonja notes from your slides, at least the US ones, and I suspect it's similar here, that tobacco use has decreased. And sometimes we think about tobacco in a different category to other drugs, etc. But it is a drug and it's addictive. what lessons can we learn from tobacco legislation, policies, et cetera, that are in place, and apply them to other potentially addictive substances? That's from left field, I know. Don't have to answer it.
Philip, do you want to go first?
Look,
well, first, you can try too. It's legal. Tobacco use is legal, so that's one big difference.
Yeah,
so
yeah. I guess
yeah,
I think it also depends. I mean, yeah, tobacco is used in a different context as well to other drugs, and I'm not sure whether we can 100% translate what has worked for tobacco to other addictions. So I'm not sure whether taxing heavily, tobacco or like making the price increase. I think that has helped to some extent. I think the economics literature shows that definitely increased prices, for at least for tobacco use, matter. They reduce tobacco use. And also, of course, the public health campaigns likely have mattered. But I think it's much harder to prove that the public health campaigns have mattered. But I think with the price, because prices can be introduced in the US, there were, for example, taxes were introduced at various points in time in various states. So you can make the case that actually increase in price did reduce tobacco use, but I'm not sure how this would translate to other drugs.
Some of the more committed social policy specialists in the audience will be aware that under the cashless debit card, you can buy tobacco, but under the basics card, you cannot buy tobacco. So that is a fascinating distinction, but I guess more directly, there's been a long-standing argument that illicit drugs should be legalised so that they can be equivalent to tobacco and alcohol, that people will pay taxation who make a profit from them, and that money, like in tobacco, will go then to health treatment and other supports for people that suffer ill health due to that use. Whether if we went down that track with drugs like heroin and ice, whether that would help a lot of people, it might help some in a particular economic way, but whether it would help people whose underlying issues for using drugs are still not addressed, I guess would be another question.
All right. So there are questions here too. Thank you. Around social policies. Let me just kind of cut over them and just talk about punitive social policies treat people pretty much as the core of the problem rather than the structural issues that seem to affect them. How do we change that dialogue? How do we move from a kind of a social system here that says, okay, you're doing these bad things behaviorally, it's, you're this, you're that, etc. And we're going to impose these different policies to try to curb that behavior, rather than perhaps something else.
I think there's a lot of people in the audience today who work in the sector in Victoria and probably remember the keynote I gave to VADA about 2 years ago, where we talked about just that, about how might we get to a different framing of social welfare / addiction issues in the wider community. And I mean, my argument would be that governments need to actually follow the co-design path to achieve real evidence about what may work. And increasingly, whether it be the cashless debit card or other areas, governments are saying in their policy documents, in their reports, we are co-designing with local communities, and even implying that they're co-designing with cashless debit card participants or other service users. But at the end of the day, mostly they're not really meeting that agenda. And my view would be, if you genuinely co-design social policies in this and related areas with both service users or likely service users and with local communities, you would develop a real evidence-based position on what is likely to work. And that position would then, I think, inform the general public in a better way, as well as the policymakers at government level.
Yeah, I think I agree with that, Philip. And also I'm just reading actually what Scott Drummond in the chat box or the Q&A box just wrote, which also relates to that, is really we have to move away from seeing the drug problem as individual failings. And I think, yeah, we can do that if we really give drug users or people with addiction some agency, and really promote and tell people that these kind of structural and socioeconomic forces are at play as well.
I am going to hand back to Dan. We do have a couple of more questions. One of the questions that we should probably let everybody know about is, will the slides be available after? And then that would be up to the two of you. So that question has been thrown out there, but we'll let you guys respond in a non-public way. Okay, we may be able to send the slides out, or maybe Dan can answer that. And handing it back over to you, Dan. Thank you, everybody, for great questions and for the two speakers. Thank you.
Thanks, Aron, and thanks again to Sonja and Philip for fantastic presentations today. Really thought-provoking, and really, it's a real pleasure to be able to invite so much talent we have here across the Monash Ethics Research Centre to answer some really key questions in different aspects of how we approach addiction. So thanks again to Philip, Aron, and Sonja. Just take this opportunity to promote our next webinar series, which is on Thursday, the 15th of July. Can cannabinoids help us address the opioid crisis? With our first international speaker, Associate Professor Kelly Dunn. So please put that in your diaries and get ready to put your name forward if you're interested in that seminar. Just to answer Aron's question, so all our presentations are recorded and will go on our YouTube channel where they'll be available viewing. So if anyone you know has missed this, or you'd like to rewatch some of the presentations, please check out our YouTube channel in about a week when they normally go up. Let me just finish by, if people aren't already aware, a major campaign that we're involved in, Rethink Addiction. So this is an independent coalition of organisations, almost 50 organisations coming together to try and call out the need to change the way we think about and address addiction and have a national addiction response. We're pleased to announce that there will be a national summit on this issue on the 31st of August in Canberra, where the Health Minister, Greg Hunt, and the Opposition Minister, Mark Butler, will be speaking and engaging with the federal government and many of our partners on this important topic. So if you're interested about that, please keep in touch. If those of you who aren't involved in the campaign, please go on the website and join either a couple of different things. Either join us on social media at Rethink Addiction, go on the campaign website and sign a petition for change, and that will give you automatic updates on events that are happening across the country. But a really exciting initiative, a really exciting campaign, and hopefully, with their first national summit here in August on addiction, it really gives us an opportunity to really strengthen that case for change across the community. So on that, it's 3 o'clock. Thank you for your attention. Thanks again to Sonja, Philip, and Aron for your time and great presentation. Thank you for listening, and we look forward to seeing you at our next webinar next month. All the best.